Historically, and even as I speak, FFS or fee for service has been and continues to be the most dominant and prevalent payment method. Hospitals and doctors are paid for each service or episode of care in the payment system. In the fee for service payment system, all the risk is with the patient or the payer. Hospitals get paid for doing stuff, and there is little accountability for value, outcomes, or results. In a fee for service system, doctors and hospitals can generally get away with poor care coordination and even poorer alignment. Results generally don't matter, and you're getting paid to do more, not better. In the event of a poor outcome, they can counsel, they can shrug and say, we did our best, and by the way, please pay the bill on your way out. Hospitals and doctors carry little to no risk in a fee-for-service system, and hence there seems to be a resistance amongst hospitals and probably amongst doctors to move away from the fee-for-service system. In a later video in this series, I'll show you a Johns Hopkins study which clearly shows that less than 7% of the doctors actually want to change the current fee-for-service payment system. It benefits everybody, especially the doctors and the hospitals. So there seems to be little incentive to move away from the current model. I'm probably exaggerating, but I'm doing that with a point, with an intent. Because the atrocity of sheer volume must be slowly diminished, and we must move towards value in a way that value can be measured and quantified. Hospitals and doctors, I agree, care for their reputation and generally would tend to do the right thing. But by its very nature, the fee-for-service model incentivizes a behavior to do more and to be paid for doing procedures, and there will always be a tendency for overtreatment and overdiagnosis for a profit motive. The FFS model also poses clear risks, as I said, for overtreatment and overdiagnosis, and it favors hospitals and doctors financially without assuming any risk. Now, this situation, as it stands today, is probably not tenable in the long run, especially as the bargaining power is shifting away from doctors and hospitals to insurance companies, to regulators, and also to patients, healthcare consumers. Hospitals are currently designed both financially and probably even structurally to make money by caring for sick people. There is no revenue model in keeping populations healthy. There is no revenue model in preventative health. The irony is hospitals may actually go out of business if populations are kept healthy. So maybe it's a good idea to look at ways in which we can compensate hospitals for keeping populations healthy using a different payment model. And we will be discussing all these alternate payment models in a while. A payment model that achieves both cost savings and also assures the best levels of care and outcomes for patients. Research scholars, health authorities, and patient activists and patient action groups have been debating patient reforms, especially in the United States and also in other parts of Europe for a while. Advances in healthcare, technology, financing, and more importantly, this debate about value in healthcare has resulted in the development and deployment of many new payment models. And these new age payment models are called alternate payment models or APMs. We will examine these alternate payment models, the emerging landscape, and then discuss the practical implications of each of these as the chorus for the shift towards value-based care from the sheer volume-based atrocity finds more resonance. Up next, payment models. The ideas that we need to cover, understand, and examine. In this section, we will look at how we've been paying for healthcare services historically, and we will also examine the new models called the alternate payment models that are now emerging. We will review the landscape with these emerging payment models and ask questions about how, with these emerging payment models, the implications of these as we shift from volume to value. What are the pros and cons of each of these payment models? Is it really possible that hospitals can be paid to keep populations healthy? Does the economic model of a hospital actually allow this? Meaning, to generate revenue and be profitable in a preventative mode. What are the different flavors of alternate payment models? Which model might be the best? Could there be a mix of models? Some innovation even within the alternate payment models where we look at hybrid payment systems. And finally, what are the implications for diagnosis and treatment depending on the choice of these payment models? Let us dive into this next.